Hello to all my friends and to my colleagues and to my fans everywhere. This presentation is for the healthcare professionals. In clinical practice, as doctors and as part of the clinical management, we have to do what we call interpretation of the investigations. So again, as part of clinical management and an important step in the clinical management after history taking and physical examination or clinical examination or bedside evaluation or bedside examination is to ask for investigations and to interpret these investigations. And at the top of these investigations are the laboratory investigations, which are done in the laboratory, as exemplified by the hematology and the chemistry, the liver function test, the kidney function test, the electrolytes, the blood urea nitrogen, urine analysis, immunology, serology, microbiology, etc. And of course, in addition to other types of investigations like radiological investigations, pathological investigations, endoscopic investigations, etc. And let me now, in this presentation, I want to stress and highlight the issue of interpretation of the laboratory tests. When the doctor receives the laboratory results for his clinical case or his patient, the healthcare consumer, he has to interpret the laboratory test results. And sometimes the laboratory results are tricky, and the clinician should focus and should understand before judging these results, and consequently will be the clinical judgment that is sorting out and deciding about the provisional diagnosis or maybe the final diagnosis in his case about his patient, regarding his patient, the healthcare consumer. So the healthcare provider or the clinician should be smart while assessing and interpreting the laboratory test results. يعني في تقييمه لنتيجة المعامل بتاعة الحالة بتاعته أو المريض بتاعه. بمعنى إن the doctor or the clinician should always remember that we are treating a patient, not a number. I will recapitulate and I will repeat that we are treating a patient, not a number. And the laboratory test results are just, when you get the CBC, for example, result, or the kidney function or the liver function test or any other type of, or urea and electrolytes, whatever the test you are assessing, it's just a number in front of you. When you interpret this number should not be interpreted alone. يعني يجب ألا يقيم منفردا كرقم، لا. نحن لو لقيناه عالي فوق النورمال reference value يبقى high، يبقى hyper. لو لقيناه أقل من الريفرنس value يبقى hypo. لا، it's not like this. لأن أنت هنا مش ده أنت مش شخص، ما هو أي شخص عادي، any one of the public can interpret the result if it is just looking at the number, and he can compare the result number with the reference range number, and he can conclude. But the conclusion of the doctor or the clinician is different, because the doctor is a doctor. The doctor should interpret and should understand that and that's why the interpretation of the laboratory values or the laboratory test results should be done by a clinician. For this reason, because the clinician should interpret and judge the laboratory results in the context of the clinical picture number 1. يعني لازم يقيم نتيجة التحليل في ضوء الصورة الإكلينيكية وليس منفردا وليس مجردا عن الحالة الإكلينيكية للمريض. The doctor or the clinician should have the clinical background, should understand the clinical background, should have the clinical background. يعني يجب أن يكون لديه الصورة الإكلينيكية للمريض بتاعه، عشان هي دي اللي في ضوءها هيقول التست ريزالت النمبر اللي قدامه ده بإكسبريس وات. What's the significance of this number? It is interpreted in the context of number 1 and the most important, the clinical picture. That's why the clinician should have seen the patient and listen to him to get the history of the disease or the history of the patient, the analysis of the patient's complaint. And then after that, he should have been examined and he should have examined the patient. That's physical examination has been done by the clinician. And then number 3, the investigations will be interpreted in the context of the first 2 steps, which are history taking and physical examination. This is very important. We are not treating numbers, we are treating patients, as said by Professor William Osler, the father of medicine, the British father of medicine, that we are treating patients. That is, the number will be interpreted in the context of this patient, the physical status of the patient as understood from the history, that's the patient's interview, and from the physical examination of the patient. And then I will say this number express what? That's why it's very important to know that we are not treating numbers. The number should be interpreted in the context of the clinical picture and in conjunction with other test results وفي ضوء التحاليل الأخرى وليس لوحده. And then in the context of all these clinical data together, that is the history, the physical examination, and the other laboratory data, we can at the end judge this number express what? Is it true or false? Because as I mentioned at the beginning, some of these numbers are tricky. And this is also what we call the pseudo values or pseudo numbers. For example, I will give examples. For example, we have what we call pseudo hyponatremia. Before judging a patient with low serum sodium level and say whether this is true or false, we should understand that there might be false low serum sodium, or what we call spuriously low serum sodium. Spuriously low يعني دي أرقام منخفضة زائفة. It is false number. It is falsely low. It's not truly low. This is the difference between true hyponatremia and pseudo hyponatremia. Focus with me as a clinician, because in some cases you might get what we call pseudo hyponatremia. Remember that in a previous lecture I have given a lecture about pseudo presentations in clinical practice, and I was talking about the pseudo clinical features, pseudo symptoms and signs. Today I'm talking about pseudo laboratory test results, like the pseudo hyponatremia. You get the result of your patient and it shows low serum sodium, but this low serum sodium is falsely low. It is spuriously low. Spurious يعني زائف, يعني false, يعني وهمي وليس not true. It's not the true serum sodium, and it does not reflect the total. And remember also that we have what we call serum sodium and total body sodium, that the sodium in the whole body, because the sodium is distributed. Yes, it is the main cation extracellular, the sodium, and the main cation intracellular is potassium, as we all know. But it might not reflect the total body sodium, and even might not reflect the real or the true serum sodium still. And this is the difference between what we call the measured sodium and the estimated or the corrected sodium. What you got is the measured sodium, but this measured sodium may be spuriously low. ممكن تكون low, may be low but false. It's not real. What are the causes of pseudohyponatremia? ما نسألك بقى في حاجات تعمل امتى when you get this pseudohyponatremia. It's well known that pseudohyponatremia is due to causes in the patient. And if you didn't recognize these causes in the patient, you will not understand that this is a pseudohyponatremia. Pseudohyponatremia happen or occur in patients with hyperlipidemias, like hyperchylomicronemia, hypertriglyceridemia, especially these cases, and also in hypercholesterolemia, but more in when the lipid molecules are large, in hyperchylomicronemia and in hypertriglyceridemia. But it happens in hyperlipidemia in general. And also pseudohyponatremia happen in patients with hyperproteinemias, like patients with myeloproliferative disorders, patients with monoclonal gammopathies like multiple myeloma, patients with Waldenström macroglobulinemia or monoclonal gammopathy of unknown etiology, or any other disease associated with high protein levels. Why? Because these proteins displace water. And when the proteins or the lipids displace water, it will cause spuriously low serum sodium. And so the result which you got is not the real sodium in the serum. And you have to correct it, to correct and calculate what we call the corrected serum sodium by special equation. Because you know that your patient is having hyperproteinemia or is having hyperlipidemia, and you should expect that if you ask for serum sodium, it will be spuriously low. Pseudohyponatremia. Pseudohyponatremia is common in the key causes are hyperlipidemia, hyperproteinemic patients who are receiving intravenous immunoglobulins for treatment, like patients with immune deficiencies, given intravenous immunoglobulins as a treatment or other therapeutic option. Patients with immune-mediated diseases. Some immune-mediated diseases are treated with intravenous immunoglobulin, like immune thrombocytopenia. These patients also you might get, if you ask sodium, you might get pseudohyponatremia. So be careful, correct it. It's not the real sodium. It's a measured sodium is low. It doesn't mean that the real or the calculated is low. No, if you corrected it, it will be normal. You will find the sodium is normal. So beware. And number, so I mentioned in patients receiving intravenous immunoglobulins. And number 4, patients with obstructive jaundice. Patients with any cause of obstructive jaundice, due to cancer head of pancreas, due to obstructive causes in the obstructive pathology in the common bile duct or in the branches. So in obstructive patients with cholestatic jaundice, you have high proteins, high lipids, you might get pseudohyponatremia also in those patients. So if you understand the clinical picture and you know the clinical background, you will understand, and you should be careful, and you must be aware that the sodium in the blood test might be falsely low. Be careful, beware. احذر. خلي بالك، خليك حريص، خليك دقيق وانت بتevaluate the results. So these are the causes of pseudohyponatremia, for example. Again, hyperlipidemia, hyperproteinemias, patients receiving intravenous immunoglobulins, patients with obstructive jaundice, obstructive pathologies in the common bile duct or in the biliary tree. Also, patients with pseudohyperkalemia due to hemolysis of the sample. You must be careful. Hemolysis of blood samples is very common from the laboratory staff, and especially in struggling patients. If the laboratory staff struggle with the patient, he get hemolyzed sample, and as a result of the hemolysis, the most common false test result is falsely high serum potassium. Here it is opposite to the عكس اللي أنا قلتها في الأول اللي هي pseudohyponatremia. Another example, pseudohyperkalemia due to hemolyzed sample. Also, another example is patients with falsely low total serum calcium in patients with hypoalbuminemia. So calcium should be corrected for albumin if you measure the total serum calcium in order to get the real calculated serum calcium, there is a special formula for calcium correction for hypoalbuminemia, because you might get falsely low total serum calcium and it's not low in patients with hypoalbuminemia. So you have to apply the calcium correction formula for hypoalbuminemia, which is the calculated or the corrected calcium is equal to the calcium minus 0.8 multiplied by 4 minus the serum albumin. This is in order to get the albumin in French units, that is milligram per deciliter. There is another equation for if you get the serum calcium in the SI units or the Système International, which are in millimole per liter units. So you should apply the equation for correction of calcium to correct the calcium for, because as we know, the calcium is bound to albumin in the circulation. And there is part of the calcium free, we call it ionized calcium. So the total calcium is different from the ionized calcium in the serum. So be careful when you interpret total serum calcium. If there is albumin disorders or problems in the patient's albumin, that namely hypoalbuminemia. So correct calcium for hypoalbuminemia or for your patient's albumin. Another example. Also, patients with anemia, when you interpret, and this is very common mistake done, and this is very tricky in clinical practice. Now I'm giving the fourth example after I gave the pseudo-hyponatremia, pseudo-hyperkalemia, the falsely low total serum calcium in hypoalbuminic patients. And now I'm giving another fourth example, the hemoglobin A1C, which is commonly done to assess the glucose status in patients with diabetes, or for diagnosis of diabetes, or for follow-up and checking your patients with diabetes to check whether he is controlled or not. In addition to, as we all know, the fasting blood glucose and 2-hour postprandial or post-meal blood glucose, we check the hemoglobin A1C in order to know whether this is a recent hyperglycemia or an old hyperglycemia, that this patient has been diabetic for more than, that is chronic hyperglycemia in an unrecognized, undiagnosed patient for long time, for example, several months or years. So you'll find that hemoglobin A1C is very high. Before interpreting hemoglobin, be careful about the hemoglobin. It is named hemoglobin A1C. It is glycated hemoglobin, so it's affected by the patient's basic hemoglobin. So it might be affected in patients with anemia, which is low hemoglobin, or polycythemia, العكس, which is high hemoglobin. So be careful when you interpret hemoglobin A1C in anemic patients. You have to look at the CBC of the patient, and you had to examine the patient to know that this patient is anemic, suffering from any type of anemia, whether it is nutritional anemia, or it is hereditary anemia, or it is hemolytic anemia, or it is anemia due to bone marrow disease, or, because all of that anemia is just a condition or a reflection of some pathology in the body. Correct for hemoglobin, whether it is low hemoglobin due to anemia or high hemoglobin due to polycythemia, whether it is polycythemia rubra vera or secondary polycythemia. This is very important. Be careful before you interpret, or while you are interpreting, and before you judge your patient's laboratory test results, because this might be tricky. We are not treating numbers, we are treating patients. The most important is the basic or the background, the clinical condition of the patient. Thank you so much, Professor Dr. Tarek Ali.